1 in 5 deliveries, I mean 20%, in the UK are induced. The outcome after IUL, 2/3 deliver without intervention, while 15% require operative vaginal delivery, 22% require cesarean section. Comparing induction of labor versus spontaneous labor, IUL is less efficient, more painful, more epidural, and more operative vaginal deliveries are required. A common indication for induction of labor is prolonged pregnancy. To avoid prolonged pregnancy, membrane sweeping is recommended for primigravida at 40 weeks and 41 weeks, while for multigravida it is recommended at 41 weeks. Offer IUL between 41 plus 0 and 42 plus 0 weeks. If a woman after 42 weeks and she declined IUL, then offer twice weekly CTG and the maximal vertical bucket amniotic fluid measurements. For preterm PROM, deliver after 34 weeks. And remember, a new GTG recommend to wait until 37 weeks. In case of PROM, offer a choice between expectant management or IUL, and it is appropriate to offer IUL after 24 hours. For women with previous CS, remember that IUL increases the risk of emergency cesarean section and uterine rupture. In case of IUFD, offer a choice of IUL or expectant management. However, immediate IUL is recommended if there is ruptured membrane, infection, or bleeding. Some women request induction of labor. Don't offer IUL routinely on a maternal request. In case of breech presentation, IUL is generally not recommended. For these women, offer external cephalic version. If external cephalic version is unsuccessful and she declines cesarean section, offer IUL if delivery is indicated after discussion of associated risk. For fetal growth restriction, avoid IUL if there is severe FGR or fetal compromise. Don't routinely offer IUL for women with a history of precepted labor. Similarly, if there are no other indication, don't offer IUL for macrosomia alone in women with suspected fetal macrosomia. Now, what is the method of IUL? A NICE guideline recommends the use of vaginal prostaglandin E2. One cycle of prostaglandin E2, vaginal tablet or gel. This includes one dose followed by a second dose after 6 hours, if labor is not established, and the maximum is 2 doses. Or to use one cycle of vaginal prostaglandin E2 controlled release pessary. This one cycle is 1 dose over 24 hours. Remember that vaginal prostaglandin E2 has the risk of uterine hyperstimulation, and we can use misoprostol in cases of IUFD. How to monitor a case of induction of labor? Firstly, assess Bishop score and confirm normal CTG before starting IUL. Then reassess Bishop score after 6 hours if used vaginal tablet or gel, or after 24 hours if used controlled release pessary. When contraction starts, perform CTG. If CTG is normal, then monitor with intermittent auscultation and provide pain relief. Regarding the complication, failed induction is one of the complications. It defined as labor not starting after 1 cycle of IUL. In such a case, reassess the woman's condition and provide options, including further attempt of induction of labor or cesarean section. Cord prolapse is another complication. To avoid amniotomy if the presenting part is high, avoid dislodging the head during a vaginal examination, and also check for low-lying placenta before membrane sweeping or induction of labor. In case of uterine hyperstimulation, consider tocolysis. And in case of uterine rupture, emergency CS is required. Thank you.